Do you know what makes left-sided and right-sided heart failure different and why understanding those differences is essential for the NCLEX? Well, we will do a deep and focused review of heart failure, emphasizing the differences between left-sided and right-sided failure, including key pathophysiology, clinical signs, diagnostic findings, nursing priorities, treatments, and patient education. Heart failure is a clinical syndrome where the heart cannot pump enough blood to meet the body's metabolic needs, or it does so only with high filling pressure that causes congestion. It may affect the left ventricle, the right ventricle, or both by ventricular failure. Knowing which side is failing guides your assessment, interventions, and the patient teaching, and this is a frequent NCLEX topic. Let's review essential pathophysiology. Left-sided heart failure. The left ventricle fails to pump effectively. Blood backs into the pulmonary circulation, increases pulmonary capillary pressure, and the pulmonary edema and respiratory compromise. There's also a decrease in a systemic cardiac output. In the right-sided heart failure, the right ventricle fails to pump blood to the lungs, blood backs into the systemic circulation, there's a peripheral edema, ascites, hepatomegaly, jugular vein distension. Right-sided heart failure often follows on treat left-sided failure, but can also result from pulmonary hypertension, pulmonary embolies, or chronic lung disease like cor pulmonale. These are key clinical manifestations, easy to remember. Left lungs, dyspnea or exertion, paroxysmal nocturnal dyspnea, orthopnea, this is going to be needs extra pillows, tachypnea, persistent cough, crickles on auscultation, wheezings, and fatigue. In acute cases, pulmonary edema with pink throaty sputum, severe shortness of breath, and cyanosis. Right rest of the body. Pitting edema in legs, weight gain, distended neck veins, enlarged tender liver, ascites, and sometimes mild jaundice due to liver congestion. Pneumonic, left lungs, right rest of the body. What about physical findings and assessment clues? Left-sided, we get crackles, rails in lung vases, possible S3 gallop, this means you have a volume overload, tachycardia, hypotension in severe cases. In the right-sided, we have a jugular vein distension, peripheral edema, hepatomegaly, ascites, and sometimes a tricuspid murmur due to chamber dilation. Always access capillary refill, peripheral pulses, and postural changes. What is the NCLEX focus on diagnosis text? Well, on the chest X-ray, you're going to see the pulmonary congestion, the cardiomegaly, and possible pleural effusion. On the EKG, prior a myocardial infarction, arrhythmias, ventricular or atrial enlargement. In the echocardiogram, this is the gold standard. It's going to evaluate the ventricular function and the ejection fraction. And finally, the biomarkers. This is going to help differentiate the heart failure-related dyspnea from pulmonary causes. And last, we're going to see the electrolytes, kidney function, liver enzymes, and especially in right heart failure and CVC. Which are the nursing priorities? Immediate assessment and action. Think ABCD. A. Airway breathing, rate for SpO2, use of accessory muscles, presence of crackles. If SpO2 is less than 90% or pulmonary edema, you have to give oxygen, sit patient up, prepare for possible CPAP or other interventions. V. Circulation. Check pulse perfusion, blood pressure, and rhythm. Continuous cardiac monitoring if it's unstable. C. Circulation and fluid balance. Check for edema, urine output, daily weights, and signs of overload. And D. Drugs diagnostics. Verify medications, ACE inhibitors, ARBs, beta blockers, diuretics, aldosterone antagonists, allergies, or contraindications. Immediate interventions like NCLEX style. Administer oxygen and monitor response. Give IV diuretics, for example, furosemide. You have to monitor urine output, electrolytes, and blood pressure. Keep patient in semi-Fowler's position, like 45 grades, to easy breathing. Monitor vital signs, in and output, daily weights, and EKG. And finally, notify the provider for low blood pressure, anuria, worsening shortness of breath, or symptomatic arrhythmias. Now, let's see the basic treatment and key medications. Diuretics. For congestions, you have to be watching for hypotension and kidney function. In IC inhibitors or ARVs, you're going to reduce the remoulating and mortality in ejection fraction. Beta blockers, used in stable chronic heart failure, not in acute descompensation. Aldosterone antagonists for select patients. And finally, vasodilators or inotropes, in acute or severe cases under provider supervision. Nurses must monitor for side effects like hyperkalemia, low blood pressure, or renal dysfunction. The NCLEX loves to test the patient education, so you have to teach this. Low sodium diet and fluid restriction if prescribed, often 2 liters per day. Daily weights. Report sodium gain more than 2 or 3 livers in 24 hours or more than 5 livers in a week. Warning signs. Increased dyspnea risk, near-to-near, rapid swelling, dizziness, confusion, or reduced urination. Medication adherence. Explain purpose and side effects. For example, diuretics, dizziness. AC inhibitors, it must cause cough and a hyperkalemia. Vaccinations, flu and pneumococcal. Manage hypertension and diabetics. And finally, on the activity. Balance rest and gradual exercise as tolerated. Cardio rehab if ordered. Let's check some NCLEX style X scenarios and reasoning. Scenario number 1. A patient with chronic heart failure presents with orthopnea and crackles, tuberosity, airway, and breathing. Give oxygen, place in semi-folders, prepare IV diuretics, and monitor urine output. Priority ABC. Second X scenario. A patient with right side heart failure shows jugular vein distension and general edema. You have to monitor bilirubin status, input and output weight, excess liver plant fluid restriction, administer diuretics, and elevate legs. The volume you have to be management. And the third is scenario. A patient on AC inhibitors reports nausea and weakness. Check for hyperkalemia, review labs, and notify provider. Medication safety. An NCLEX tip. Always prioritize acute changes. Shortness of breath, hypotension, no urine output, and apply ABC plus reassessment logic. Complications to watch for. Pulmonary edema. This is an emergency. Cardiogenic shock. Arrhythmias, especially in atrial fibrillation. Kidney failure due to low perfusion or medications. Early recognition 6 points on the exam and lights in real practice. Finally, let's see some useful phrases for NCLEX reasoning. First, I access airway and breathing. If there are crackles or low SpO2, I give oxygen and sit the patient up. If I see jugular vein distension and leg edema, I think of right-sided heart failure or fluid overload. I check input and output and daily weights. I always connect the clinical picture for EKG, echo, and BMP when available. Thank you for joining this review. If you join this session, you're joining our community of Enfermeras en USA. Save and share this video and follow us on our platforms for more NCLEX tips, case studies, and clinical reviews. See you in the next session and best of luck on your NCLEX journey.